Hello, good morning everyone. Today I am going to talk about preterm labor, the prediction and prevention in this first video, and we will have two parts. In the second part we will discuss about the diagnosis and the management. So preterm labor is defined as the onset of labor pains before 37 completed weeks of gestation. There are various causes. It is multi-factorial. The common causes are infection, cervical abnormality, uterine malformations, overdistension like multi-factorial gestation, polyhydramnios. Of these, 20 to 40% cases are because of infection. Then we have to see how we have to predict preterm labor. There are certain points in the history, certain points in the ultrasound, and there are certain biochemical markers by which we can predict preterm labor. Let us see the points in the history. If the woman has a previous history of preterm labor, the risk of preterm pregnancy in this pregnancy increases. If she has history of one preterm labor, the risk in this pregnancy is 16%. If there is a history of two preterm deliveries in the previous pregnancies, then the risk is 32%. And if she has history of three preterm deliveries, the risk is around 62%. The other factors are previous history of mid-trimester loss, that is more than 16 weeks of gestation, previous history of preterm pre-labor rupture of membranes, previous history of cervical surgery, trauma, trachelectomy, short cervix, bacterial vaginosis. These are all the high risk factors. There are certain intermediate risk factors like previous history of cesarean section which was done at full dilatation, previous history of cone biopsy, previous history of cervical surgeries which is more than 2 surgeries on the cervix, and large loop excision of transformation zone more than 1 centimeter. So now if on the history we know that these are the high risk factors, we have to put that woman on cervical screening by transvaginal ultrasound. This is done from 16 to 24 weeks of gestation, and if the cervical length is less than 25 millimeters, she is at high risk of having preterm birth. If the cervical length is less than 25 millimeters at 21 to 25 weeks, the risk is still higher. So if we have predicted that she is at risk, what we have to do for the prevention of preterm birth? For prevention, we have to treat the high-risk women of asymptomatic bacteriuria, for the presence of symptomatic urinary tract infection, bacterial vaginosis, periodontal disease. Now, what we have to offer her? There are two choices. Number one is the prophylactic progesterone therapy. Second is a prophylactic cervical cerclage. If she has both the factors, one from history and one from ultrasound, we will offer a choice of prophylactic progesterone or cervical cerclage. So what is the factor from the history? From the history, if she has a previous preterm birth before 34 weeks of gestation or a mid-trimester loss after 16 weeks of gestation, this is the history factor. The ultrasound factor is at 16 to 24 weeks if the cervical length is less than 25. So if both the factors are there, we will offer a choice, but we will prefer cervical cerclage. We will also prefer cerclage if the cervical length is less than 25 millimeters at 16 to 24 weeks. Along with this, she has preterm pre-labor rupture of membranes or cervical trauma like cervical surgery. Now, in which cases we will offer vaginal progesterone? It is offered in low-risk women in whom after cervical screening or routine ultrasound scan is showing that the cervical length is less than 25 millimeters. It is offered in high-risk women who is undergoing cervical length assessment and we find that the cervical length is less than 25 millimeters. And the third point is, as we discussed earlier, if she has either of the point, one from history and one from ultrasound, so only history point is there or only ultrasound point is there. So in such cases we will offer progesterone therapy. What are the different types of cerclage? Let's see. One is history indicated cerclage, which is a prophylactic cerclage done at 11 to 14 weeks. Here the woman is asymptomatic at present, but she has history of 3 or more previous preterm births. Second is a ultrasound indicated cerclage. This is done during cervical screening between 16 to 24 weeks when the cervical length is less than 25 millimeters. So this is a therapeutic cerclage. History indicated is a prophylactic cerclage. Third is a transabdominal cerclage. This is done when there is a history of a previous preterm birth in spite of a cervical cerclage, or the cervical tissue is so less or deficient that it cannot hold the stitch in place. Fourth is the emergency cerclage, that is a rescue cerclage. This is done when the patient presents with the signs and symptoms of preterm labor. She is having contractions, she is in labor, but the cervix is not more than 4 centimeters dilated, and the membranes are there which are bulging, but the membranes are not ruptured. So it helps to improve the survival of the neonate and reduces the risk of serious neonatal morbidity and mortality. And it also helps to prolong the pregnancy by 34 days, and there is a 2-fold reduction in the incidence of delivery before 34 weeks of gestation. The contraindications for the rescue cerclage are uterine contractions, active vaginal bleeding, and if she has some uterine infection. The do's and don'ts in cerclage is that in history indicated cerclage we have to do the aneuploidy screening and the dating scan. Before ultrasound indicated cerclage we have to do the anomaly scan. Routine amniocentesis, routine use of tocolytic drugs, routine genital screening before cerclage is not indicated. The WBC count and CRP is done depending on the clinical condition of the woman. The type of surgery, the type of anesthesia, the type of suture material, everything is dependent on the surgeon's discretion. After cerclage, the bed rest is not routinely recommended. Prophylactic progesterone is also not routinely recommended after cerclage. And then a repeat cerclage is also not recommended. Cervical length screening is not recommended after cerclage. So these are the do's and don'ts which we have to follow. The complications of cervical cerclage are pain, infection, vaginal bleeding, increase in uterine contractions, and preterm delivery sometimes. Where the cerclage is contraindicated are fetal congenital malformations, fetal death, chorioamnionitis, any vaginal infection, and congenital malformation of the baby, and chorioamnionitis. When the suture is to be removed, it should be removed between 36 to 37 weeks of gestation, or whenever the patient comes in active labor. In transabdominal cerclage, the suture need not be removed. It has to be kept in place. The delivery is by cesarean section. So this is all about the prevention, prediction, and the details about the cerclage. So if you like the content of this channel, please subscribe to my channel and don't forget to hit the like button. Thank you.